On behalf of the Patient Safety Authority, I'd like to welcome you to this web conference titled Overcoming Challenges in Pressure Injury Reporting, Two Facility Perspectives. My name is Jeff Bomboy, and I'll be your moderator for this program. Now I'd like to introduce our first speaker for the webinar. Melanie Motz is a patient safety liaison with the Pennsylvania Patient Safety Authority. She interacts with patient safety officers and other various healthcare staff in healthcare facilities across the eastern region of Pennsylvania in an effort to decrease patient harm. Our second speakers are Gail Walsh and Stormy LeMay. Gail currently serves as a patient safety coordinator for Reading Hospital, a Tower Health entity. She began her career as an intensive care nurse. She was a director in both a freestanding and hospital-based subacute care unit. During the past 8 years, she has served as patient safety and/or risk management coordinator. She is responsible for coordinating the patient safety activities of the Reading Hospital and Tower Health associated entities, including but not limited to supporting the patient safety program on a day-to-day basis, managing and analyzing event reports and data, conducting event investigations, and providing patient safety educational programs in support of the Director of Patient Safety. Stormy serves as a wound, ostomy, and continence nurse at Reading Hospital, a Tower Health entity. Prior to obtaining her BSN, Stormy worked as a licensed practical nurse at an inpatient rehabilitation hospital. Our third speakers are Michelle Crum and Jennifer Fimiani. Michelle serves as Manager, Risk Department Treasurer for the Pennsylvania Association of Healthcare Risk Management. Michelle's been a registered nurse for 34 years, working in pediatric rehab, home health, maternal child health, including NICU, but most recently as risk manager for the past 12 years. Jennifer serves as an acute care certified wound ostomy specialist at Penn Medicine Lancaster General Hospital. Jennifer Fimiani's unique perspective on pressure injury prevention and wound care is defined by her experience across the healthcare continuum. She began her nursing wound care career in public health, supporting a homeless health program in York, Pennsylvania. Mel, now I'll turn the program over to you.
Thank you, Jeff. Good morning, everyone. Thank you for joining us today. To get started, I'm going to focus on the following objectives. First, I will summarize pressure injury reporting requirements that went into effect on January 1st of this year. Secondly, I'm going to review preliminary baseline data we have collected in PACERS through the end of February. Then I'm going to turn the presentation over to two healthcare facilities, Reading Hospital, a Tower Health entity, and Penn Medicine Lancaster General Hospital. Both facilities had offered to share what they're doing in their hospitals to identify, assess, and monitor pressure injuries. Our goal for this webinar is that you can take away some ideas and or strategies facilities are using to use and implement in your own facilities. So some of you are probably wondering why we chose to standardize pressure injury reporting. And the answer is really to minimize the inconsistencies we saw in our analysis of pressure injury reports. There was a lot of variation in how facilities across Pennsylvania submitted reports, and this was highlighted in our patient safety advisory from March of 2015. For example, our analysis showed that staging wasn't included in 1/3 of the reported pressure injuries. And over time, we saw an increase in the number of reports at deeper stages of tissue damage. We know pressure injuries, formerly known as ulcers, are a quality indicator and can affect or have affected reimbursements in your hospital. Lastly, we saw a majority of events were being reported as incidents or events with no harm to patients when pressure injuries were hospital-acquired and or involved deeper stages of tissue damage. So ultimately, our goal in standardizing reporting is 1, to implement clear standards in reporting pressure injuries, 2, to produce reliable data and analytic reports, and 3, with a combination of 1 and 2, to continue to provide risk reduction strategies to you to prevent hospital-acquired pressure injuries and progression of pressure injuries present on admission. We are challenging you to identify these pressure injuries, stage them, and prevent them from deepening, and report them into PA-PSRS to assist us in analyzing and developing further improvement strategies. Now, as I mentioned, we did publish an advisory article on pressure injuries being a top concern for hospitals in March of 2015. And in this, we do list a number of risk reduction strategies and a list of evidence-based pressure ulcer prevention guideline resources for you to tap into. The article is referenced at the end of my presentation, so please be sure to check it out. The final guidance was published in the Pennsylvania Bulletin on April 8, 2017, and in summary, all hospital-acquired pressure injuries that do not require additional healthcare services and those that progress from admission but do not require additional healthcare services are reportable into PACERS as incidents or an event with no harm. Any hospital-acquired pressure injuries that progress or worsen during hospitalization that require additional healthcare services are reportable as serious events or events with no harm. What's important to note that is not reportable is deep tissue pressure injuries upon admission, or those pressure injuries present on admission that remain stable or improve. Hence why it's important to do baseline skin assessments on all patients upon admission and at regular intervals throughout their hospitalization. It's an opportunity to identify, treat, and monitor as necessary. If there are multiple pressure injuries on a patient, you're only required to report the deepest stage. For example, if a patient has 2 stage 1 pressure injuries on their buttocks and a stage 2 on their heel, you would report the heel pressure injury into PA-PSRS. You do want to report any worsening or progression of a pressure injury. And now we do have a new category in PACERS to report any medical device-related pressure injuries. For example, from oxygen mask or tubing, tubing from a Foley catheter, or mucosal ulcers, such as in the mouth or in the nares. We've also created a decision tree tool that was published as a part of the final guidance for you to use as a resource to assist you in deciding how to report or not report an event. I do think it's important to note that pressure injuries upon admission are not reportable. We are still seeing these reported into PACERS since the new requirements went into effect. And I know from my experience in speaking with facilities personally, they've reported them into PACERS as a tracking system. But I do want to make mention that it is not necessary to report those. We do hope that you are finding this tool helpful. And for those of you who are not familiar or who haven't had a chance to complete the online education available, I do suggest you check it out. We published online education through our learning management system in November of 2017. The purpose of this education is to assist you in applying the final guidance principles with real-life case scenarios. There are 3 reporting modules that give you an overview of the guidance, as I have today, frequently asked questions, and application of those principles in real-life case scenarios. And lastly, a module highlighting the PA-PSRS changes that went into effect. For example, the new staging categories and new questions that we are asking. You will receive 1.5 continuing education credits for completing these modules. Then we have 1 prevention module that outlines updated evidence-based guidelines from the National Pressure Ulcer Advisory Panel and from the Wound Ostomy Continence Nurse Society. This addresses risk factors and interventions to assist you in preventing hospital-acquired pressure injuries from occurring. You will receive 1 continuing education credit or 1 CME if you are a physician completing this education. I do recommend sharing these modules in your organizations or facilities to those you feel would benefit from completing them, as they are free education. To access the education, you want to use the web address noted here. If you've not completed online education we have published in the past, you will need to register to access the education, which you can do by clicking on the Register Here link in the top right-hand corner of the computer screen. That's where that red arrow is pointing. We have numerous education opportunities and free continuing education opportunities through our learning management system for you to take advantage of. So now I'm going to share some of the very preliminary data that we've collected from the first 8 weeks of 2018 since the new pressure injury reporting requirements have gone into place. We thought this would be interesting information to share with you all. So in this chart, you can see what modes are being used to report events into PACERS. For those facilities who have an interface directly into PACERS, stages 1 and 2 can be reported through this interface, and for those facilities who do not, you're required to submit them manually through the PA-PSRS online application. And all serious events are required to be manually submitted through the PA-PSRS online application. So you can see submissions are about even. 55% of pressure injury reports are being manually submitted into PACERS, and 45% are being submitted through the interface. Here you can see that a majority of pressure injury events are being reported are incidents. So 88% of the reports coming in are incidents and 12% are serious events. I can tell you that we did expect to see a small increase in harm score E events, or those meeting requirements of a serious event, with the new requirements, and based upon our historical analysis, as I shared with you earlier in the presentation. And of most interest, you can see the types of stages and the types of pressure injuries that are being reported. So the number one pressure injury stage being reported are stage 2. These account for approximately 41% of the reports. And the number 2 pressure injury stage being reported are stage 1. And these represent almost a quarter, or 24% of the reports. And the third most reported are deep tissue injuries. These account for 16% of the total pressure injury reports. We've noticed medical device-related pressure injuries are being reported under the pressure injury stage. Therefore, the 2% might actually be a little bit higher than what is depicted here. And lastly, here's a snapshot of some of the question responses we ask in PA-PSRS. You can see question 1, how many pressure injuries does the patient have, including the one you were reporting? A majority of patients only have 1 pressure injury present when reporting. And question 2, was the patient assessed for pressure injury risk prior to the development of the pressure injury? Over 70% of patients have been assessed for pressure injury risk prior to the development of a pressure injury, and just over 20% is unknown, which may mean there are opportunities for improving skin assessments. And now I'm going to turn my presentation over to Gail and Stormy from Reading Hospital.
Thank you, Melanie. My name is Stormy, and the objectives for today's discussion are to discuss the role that the WOCN plays in pressure injury identification, treatment, and collaboration with patient safety, and to also discuss the role of the patient safety in monitoring, and reporting pressure injuries. I am one of 3 WOCNs for the Reading Hospital. We are a 700-plus bed facility, which includes our psychiatric hospital, along with our inpatient rehabilitation facility that is located off campus. With having such a large facility, the WOCNs do need a little bit of help from our bedside staff. We are lucky to have skin wound resource nurses, or what we like to call them is our SWAN team. So the mission of the SWAN team is to utilize best nursing practice, which integrates best evidence and research to improve patient outcomes related to skin and wound assessment and care. The SWANs provide education, support, and guidance to the other bedside staff on their units. SWANs are all registered nurses, but we do have others who attend our monthly meetings. The whole team consists of registered nurses, patient care assistants, nurse managers, clinical nurse specialists, and any other disciplinary team that we find we may need some assistance from. We review the past month's hospital-acquired pressure injuries and discuss any trends that we may be noticing and how we can improve upon them. Quarterly, we have our National Database of Nursing Quality Audit, or NDNQI. This audit consists of the SWANs and the PCAs assessing every patient in the hospital for pressure injuries, be it hospital or community acquired. If they do find an area, they will notify one of the WOCNs, and we will then go confirm if this area is in fact a pressure injury. The registered nurses then review that unit's nursing documentation, and all the information is then provided to our quality officer, who compiles it up to send out. After every NDNQI audit, the SWANs put together a process improvement plan on how they can improve and/or prevent pressure injuries for their unit. If a unit obtains a hospital-acquired pressure injury during a non-NDNQI month, they are also then responsible for creating a process improvement plan. This plan is reviewed by the unit's clinical nurse specialist, the nurse manager, the SWAN, and the WOCN prior to any education or implementations beginning on the floor. So this is an example of the pressure injury report that the team receives monthly. The report shows the unit that the hospital-acquired pressure injury was found on, the location on the body, the pressure injury stage, and if it was related to a medical device. If it was related to a medical device, that's also listed on this report. And the report is then sent to the WOCNs, the clinical nurse specialists, nurse managers, divisional directors, and the SWAN team. So our skin assessments and prevention begin on admission of the patient. We encourage the bedside staff to perform a dual skin check upon admission or transfer of the patient. This check consists of either 2 RNs or an RN and a PCA. They'll perform a head-to-toe assessment and document any skin abnormalities they may find. Any open areas, pressure injuries, or any area in question will have a lines, drains, airway, and wound property column open. This is what we call an LDA. Staff will then perform the Braden. A patient with a Braden of 18 or less is considered high risk, and staff are to follow our pressure injury prevention policy. Our policy lists the different Braden scores and the recommended implementations for each, such as the sacral epaulet, low air loss mattress, heel elevation, and so forth. And even though we have this policy in place, this is just a guideline for the staff. They are encouraged to look at each patient as an individual, and if they feel a patient may benefit from a specific intervention, they are to then apply it. During the assessment, staff will then consult the WOCN if they have any questions or concerns in regards to a wound or pressure injury. So this is an example of what our LDA looks like. The staff will open this up when they find a wound. The staff will assess the wound base and measure. The measurements are performed twice a week, and this allows staff to monitor if the wound is improving or worsening. And if it is worsening, they can reach out to the WOCNs to evaluate it or reevaluate it. So if a staff member notices a pressure injury and it's after 24 hours, they will open up an LDA, and one of the questions is, was this present on admission? If the nurse checks no, it's going to trigger this to pop up, which will remind them that they need to place a consult for the WOCN so we can go assist them. Per our policy, registered nurses are able to place a consult for the WOCN, and this is how the consult page looks. So staff place a consult, and then they put down that this is as per protocol, and the physicians will then sign off on that. Staff fill out the incident report in regards to the pressure injury, and then this report goes to the nurse managers, the CNS, the WOCNs, and the safety officers. So once the WOCN receives a consult or the incident report, we will then go assess the patient. If the area is indeed a pressure injury, we will discuss with the bedside staff any recommendations for wound care and make sure that all implementations are in place. Once this is done, we will then review the incident report and make any corrections necessary, and we perform a chart review to look back on the documentation to see where any breakdown may have occurred. So this is an example of our wound audit tool. This we look back on to see the nurse's documentation. So we have a quick look at how often the patient was repositioned, if heels were elevated, and any skin care that was provided. Once this is completed, we will write up a report and send that out to the unit's nurse manager, their clinical nurse specialist, and the unit SWAN. If we assess the patient and find that there is no pressure injury, we'll speak with the staff as to why this area is not one, and then we will write recommendations for wound care, and we'll also ensure that proper implementations are in place to prevent any pressure injuries from occurring. The WOCN will update the incident report to reflect our findings, and then we'll send an update to our patient safety coordinators. So this slide shows an example of one of our WOCN notes. We include the LDA for the wound so everyone can see measurements and the base assessment, and it also lists what dressings and treatment we're doing. We'll write our progress note to include any of our findings and recommendations, and at the end of our note, we'll include a photograph of the wound. This allows everyone to see the wound without having to remove the dressings. It also allows us to assess if there's any improvement or worsening of the wound. I'm now going to turn the rest of the presentation over to Gail.
Thank you, Stormy. I'm Gail Walsh, one of the patient safety coordinators. In the patient safety department, we are very fortunate to have this collaboration with the WOCN team. RL Solutions is the platform that we use to enter event reports. There's a journal event type called skin and tissue, and then we're able to drill down into a more specific event type, which is called pressure injury. Included in RL Solutions are the new questions that are specific to pressure injury reporting requirements. Those questions that have a green star in front of them are mandatory for completion by the frontline staff. These questions provide us with valuable information such as where was the pressure injury acquired? Staff have a drop-down box to select either present on admission or hospital acquired. Was the event related to the use of a medical device? How many pressure injuries does the patient have, including the one that we're reporting? Was the patient assessed for pressure injury risk prior to the development of the pressure injury? Were any preventative interventions implemented prior to the development or progression of the pressure injury? Was the pressure injury a progression or worsening of either a hospital-acquired or present on admission? What is the stage of the pressure injury? And what are the following risk factors that likely contributed to the pressure injury? And this is actually a pick list, so some selections could be BMI, friction and shear, limited mobility, and terminal illness. And you'll recognize that these questions mirror what you're required to complete in PA-PACERS. We have the ability to pull data from any one of these questions to look for trends and process improvement opportunities. In patient safety, we stay focused on learning opportunities from each event report. RL Solutions will also send an email alert out to the content experts and those members of the management team who are responsible for that particular patient. And for pressure injuries, those alerts go out to the manager and director of the involved department, the WOCN team, the Clean Nurse Specialist, and the Patient Safety Department. And here's an example of that email alert. Those content experts or managers just click on the link associated with the file ID number, and it will take them directly into the incident report. The great collaboration that we have with the WOCN team helps us to ensure that these events are accurate so that we are only reporting true pressure injuries based on the reporting definitions and requirements. If the incident is deemed not to be a pressure injury, it is changed into a more appropriate category by the WOCN. And some typical changes that we see at Reading are it could be an abrasion, diaperdermatitis, or rash. And the WOCN team will also provide just-in-time education as warranted to staff when the incident does not meet the definition of a true pressure injury. The WOCN team will also notify the Patient Safety Department via email that the incident report has been corrected. If the incident is a true pressure injury, then we have created a log to help us track and trend this type of incident. This log has also been very helpful to guide us in taking the appropriate steps to make sure that we're meeting the requirements for reporting these events. And here's an example of our pressure injury log. Event date, patient's name, medical record number, incident report number, department, and description are key facts that we like to have included on the log. And any pressure injury incident report gets entered onto this log. It's been very helpful to add the medical record number and RL Solutions number in case we need to review that incident report or go back into EPIC to review the medical record. We do take the time to complete the description so that at a later date, if we're required to do a manual submission to PA-PACERS, we just paste that information into the report, and we've really found that to be a time savings. Then we identify in this log, was it present on admission or hospital acquired, what stage we're reporting. If we do a manual submission, what date we submitted at the PACERS number, if we have to amend the PACERS report, what the severity level is, the disclosure letter is sent, any follow-up, the WOCNs are notified, and the patient's discharge date. And something that we might put in the follow-up column is if there's a note in the record from the WOCNs that they're going to reevaluate the patient in a week, or if we have to notify risk management. This pressure injury log has really helped us to stay organized since there are two of us in patient safety who review the event reports on different weeks. This pressure injury log is reviewed at least weekly, but typically we review it every other day. We're concerned if the pressure injury has had a progression or if there's been a development of the pressure injury. If we have a patient that has a stage 1 or 2 pressure injury and they've been discharged, we just sign off the incident report, then we send it via the interface to PA-PACERS, and on the log we yell out that information. To reduce the time it could take to amend a report in PA-PACERS, we have initially decided to not close those reports that meet the definition of an incident until the patient has been discharged. We do keep in mind the 90-day requirements that are in place to report incidents to PA-PACERS. And so far this strategy is working, but we're open to reevaluating it in 6 months once we have more time and data to review. Now, if the pressure injury is considered a serious event, which warrants manual submission to PA-PACERS, we do report it manually. A disclosure letter is completed, and we add it to our serious event lister log, which I'll share that with you in a moment. Some sample verbiage that we created in collaboration with the WOCN team to add to a portion of the disclosure letter was important to us because we wanted to make sure that our patients understood what was being disclosed. So here's 2 examples. In your case, you developed a pressure area that required treatment, or in your case, you developed an area of skin that broke down and required treatment. And this is an example of our serious event list or log, and it looks very similar to the pressure injury log, but this is also used by our risk management department. It includes all serious events. While this is another step to add the pressure injuries that meet the definition of a serious event to this log, we have found it to be a time savings, and it really is a minimal effort on our part. And it's really important because not only patient safety but risk management uses this log, and it also serves as a quick reference for us. Stormy and I want to thank you for providing us with this opportunity to share with all of you how we're managing pressure injury reporting requirements in an organization that has a strong collaboration between the WOCN team and patient safety. And we are happy to provide you with any additional clarification or to answer your questions at the completion of this webinar. But now it's my pleasure to turn this program over to Michelle and Jennifer.
Good morning. This is Michelle Crum. I'm manager of the risk department here at Lancaster General Penn Medicine. So we just want to say thanks for letting us come and share with you the things that we're doing to improve patient safety and skin integrity with our patients. Let you know we have no conflict. We wanted to let you know our objective is to identify the opportunities to decrease hospital-acquired pressure injuries with real-time reporting. Learn how real-time reporting of hospital-acquired pressure injuries was established here at Lancaster General Hospital, and understand the impact of the data that has improved collaboration of interdisciplinary stakeholders and subsequent reduction of hospital-acquired pressure injuries. So a little bit about Lancaster General Health, Penn Medicine, that we are an integrated system with 3 hospitals. We have 15 outpatient locations and a very, very large physician network group. We also have a PA college associated with us, so we work with a lot of students who come through our doors and caring for patients with us. We service Lancaster County, a region of about 890,000 people. We have 689 licensed beds. We had inpatient discharges of 35,000, well over $1.5 million outpatient visits, $1 billion plus revenue. We do greater than 38,000 surgeries per year in our 40 operating rooms, and we're coming close to 8,000 employees and 900 plus staff members. We joined Penn Medicine August 1st, 2015. So we've been able to coordinate with them as well, learning opportunities. A little history about pressure ulcers, just some basic data. 2.5 million people are affected each year with pressure injuries, and it is a cause of death for about 60,000 people per year. The cost is amazing. We're into the $11 billion, and of course, as a risk manager, we're very careful about how this affects us with lawsuits. There is a word of about 17,000 lawsuits annually related to pressure injuries. It is the second most common claim after wrongful death. So more than falls, more than emotional distress, we have lawsuits related to pressure injuries.
This is Jennifer Fimiani. I'm one of the WOCNs here at Lancaster General Penn Medicine. Thanks for having me here today. So in August 2012, it was identified that we had a hospital-acquired pressure ulcer rate that we like to consider reached the high water mark. Not something you're proud to say, but certainly our prevalence studies quarterly revealed that we had a 5% of our patients had hospital-acquired pressure ulcers. Nationally, we were ranked in the lower decile compared to other hospitals our size. So October 2012, the journey began, and really what we realized is that there needed to be a call to action with some real-time reporting when pressure injuries, or now pressure injuries, then pressure ulcers were discovered. And this was the process that we developed. The staff nurse, similar to the previous presentation, we have similar criteria and similar nurse-based initiatives for 2-person staff nurse assessment documentation, and staff nurse protocols and interventions that they can initiate. The second piece that we put in is when a hospital-acquired pressure injury was discovered or thought to be discovered of any stage, that pressure ulcer, as it was called at the time, was then to be validated by the certified wound ostomy nurse. That included doing a consult to us with all those interventions in place so that we can validate the findings. The rate definition that we used was number of HAPUs per 1,000 patient days, and we report both daily, real-time hospital-acquired pressure injury reporting, monthly, weekly, and then certainly year-to-date. So this is our challenge, and this is the challenge I think we see both throughout PA but nationally, is that your nurses, your staff nurses, roll the patient over, and this is what they see. And how do they, this is a global question, how do they stage this? What do they write present on admission? And that continues to be a challenge both for staff nursing as well as providers to get everybody on the same page. I'm going to go back one slide so that you can see. Okay. There we go. In this picture, what we really want to say is we want the nurses to understand the staging, and we continue to teach on that. But certainly for our documentation purposes, we want them, as I like to say, use your words. So describe the location to the best of your ability, the color of the wound, the depth, partial thickness, full thickness, opening, because we know that these wounds progress rapidly or can, that we don't always capture it well with using the pressure injury staging guidelines that we have available right now. And getting that processed across all staffing, it continues to be challenging. So not only do we ask them to pressure ulcer stage, but to use their words in their two-person skin assessment note. In this case, we would ask them to use a color, including echomotic or purple. Certainly here we also see some partial thickness openings. There's vast locations here, both on the coccyx and ischium and sacrum. So after the description is made, we certainly do not want the assessment or pressure ulcer staging to necessarily drive our care. The reality is the patient you just saw will have similar interventions based on the Braden that they receive and the risk pieces that are identified by the nurse. So this is all evidence-based skincare policy that then drives. So based on the picture you just saw, depending on whether the patient called it a DTI or a stage 2, quite honestly, the interventions are the same because we're going to offload that area. We're going to manage the moisture. We're going to do all those things in the Braden. So although we certainly ask them to stage, the interventions are not based off staging. They're based off those risk factors that are identified by the nurse on admission and throughout their hospital stay. The skincare policy that those interventions are based off certainly is evidence-based. It was endorsed or continues to be endorsed annually by the medical dental staff and certainly empowers the nurse to put those interventions into place in a timely manner. The prevention is similar to the process you heard in the previous report from Reading Hospital. We have similar monthly audits by the skincare champions. That's what they're called in this facility. We do daily reports to electronic health record, daily unit-based quality rounds that are done, and we continue to use some of this data that we're collecting to evaluate our products and equipment. We have also found, as Reading has, that a two-person skin assessment is certainly very important both on admission and on transfer of that patient to another unit. So our skincare team certainly is multidisciplinary. We do have the certified wound nurses like myself. There are 2 of us in our facility. But our skincare committee is made up of unit-based skincare champions, which are ultimately important to give their perspective on the initiatives and barriers to those initiatives that we find. We have a physician leader. Certainly risk management is a large part of that interdisciplinary team. A data analyst. We incorporate some of those other departments, such as peri-op services, emergency room, and respiratory therapists, which are integral for looking at our device-related pressure ulcers we have found. Certainly equipment, such as purchasing and patient equipment services are involved, and then our colleagues in dietitian and physical therapy and informatics. So when a pressure ulcer is identified and is consulted to validation to the WOCN or the skincare champion, and we send it back as a report to the manager and to the unit, the second thing that we have created is what we call the why questions. So take NG tubes, for example. Previous to doing this why question analysis, the answer to the root cause analysis to an NG pressure ulcer was they had an NG tube. And we all know that as the basic answer. The challenge is that why did they get that pressure ulcer from the NG tube? What could we have done differently? What do we have in place that worked or didn't work or they weren't able to obtain? So we're constantly looking at our analysis of whether what we have is working or whether there are barriers in place that they are unable to obtain the products that we have available. This has really helped us look at our process to a deeper level. This is some of our numbers as we currently have them. And in this, I know this is a very small chart for you to see up on your screen, but the key pieces I want to point out is we certainly do the plan, analysis that you see up in that corner. But in addition, all those kind of green boxes that you see coming off this chart are where implementations were made, where changes were made, where different products were rolled out based on some of that analysis. And sometimes a product can increase your pressure ulcer rate because now there's more awareness of that area. So it is constantly looking at what is the root cause and what is causing and what we can do better. I would highly recommend a surveillance versus an incidence. The surveillance is a daily look at your hospital-acquired pressure injuries versus a once-a-month incident snapshot. Wound photography certainly has been integral for us. When we have pressure injuries, we're able to, in that real-time conversation that we send out to managers, directors, risk management, show the picture as you see here of some of the areas in question. Sometimes, just as Redding had alluded to, the pressure injuries that were called upon that we come to validate are indeed not pressure injuries. They are moisture, they are shear, they are other things. They are a viral infection. And so by taking pictures of those as well, we're able to educate our staff on kind of some of those outliers that should not be included in the pressure injury data collection. We, as in most folks today in the United States, I dare say, use the National Pressure Ulcer Advisory Panel staging guideline. Injuries, as they're called now, you do see up on top, we continue to use both injury and ulcer until CMS also has some updates in their terminology. But we do instruct to that. We provide this actual definition within our charting that we use, our electronic charting. They're able to pull this up real time when they're attempting to stage the pressure injury that they have found. So real-time root cause analysis, the deep dive is done by the skincare champion, and that is important because it's their peers that they're asking during daily huddles about those why questions. We want to hear from the staff nurses, why, as the example I gave, the NG tube caused the pressure injury. Is it because they didn't know what to use, how often to assess? And we are all dealing with, both in PA and nationally, what we sometimes try and categorize is unavoidable pressure injuries. Sometimes the why questions that we get back are, it's an ECMO patient and we have challenges with turning and desatting. That is some of the stuff that absolutely we want back on those why questions. So we turn that into lessons learned. Those lessons then go to the hospital-wide skincare committee to share. That unit that did the deep dive then shares their findings with their peers. And then we look at trends to locations and devices for opportunities for improvement. We continue to move forward in our process and looking at some of our pressure ulcer rates. This is how we kind of delineate out unit by unit. We attempt to really pull out one unit from the other to see where our challenges are. Currently, as you can see from this, most of our pressure injuries that we have challenges with right now are from devices and are in our critical care units. This is an interesting slide because it does kind of superimpose one year from the other. Our pressure ulcer rates going forward, as you can see. And I think now I will hand it over to Jeff. I will turn the program over to you.
Okay, thanks, Mel, Gail, Stormy, Michelle, and Jennifer. That was a very informative presentation that contained valuable information everyone can use in their organization. That concludes our slide presentation portion of our program. Now we would like to begin our question and answer period. So I have one question here, I would imagine for one of the panelists from the facilities. It says, for those patients whose facility uses wound photos to document and monitor wounds, how often are the photos being taken?
So this is Jen from Lancaster General. Certainly had a lot of photos in that presentation. Currently at Lancaster General, we are, the wound ostomy nurses are taking the photos. They go directly into our EMR, so we're not, do not have cameras. We actually use hospital-owned iPhones, and the data is not kept on the phone. Open up the EMR on the phone, it goes directly into their hospital record. The consent is on the direct consent that they sign when they enter into the hospital, and we do take follow-up pictures as we're following these hospital-acquired pressure injuries. We do not right now have a criteria or the manpower to take all present on admission photos. Certainly, as two of us, we'd be doing a lot of them. We do certainly take some that we validate as non-pressure injuries for educational purposes, but right now the WOCNs are the ones taking the photographs for pressure injury. Did you have something to add, Tori?
Yeah, so we pretty much do the same thing as they're doing. The photos go right into the chart. They're not hanging out on the phone or in the cloud. We typically take the picture when we see the patient on an assessment, and then we do follow-ups with them either later in the week or the following week, and then we'll add in another picture so we can do comparisons along with the measurements of the wound.
Okay, thank you. We have another question maybe one of the wound nurses can answer. When reporting the worst wound to PA-PSRS, when you have a deep tissue injury versus a stage 3 or greater, which is considered the worst one?
It's Stormy. So I would say we're probably going to do the stage 3 or greater because with a deep tissue injury, we don't necessarily know what's going on under there. But when it comes to stage 3s, 4s, we have a better idea. But we will monitor the deep tissue injury so we can put forth any information to the Patient Safety Authority if we need to.
This is Jennifer from Lancaster General. I would say we do the same. The challenge with the deep tissue injury is often the etiology or the deep tissue injury isn't always clear. You have, vasoconstriction, you have bruising, you have DTI, and sometimes it's not an immediate understanding of what you're dealing with some of these areas. 3 or 4 is much cut and dry as a full thickness injury from pressure. So we would do the same as reporting that stage 3 or 4.
Okay, thank you. Here's another question. Perhaps Mel can answer this. We currently submit incidents to PACERS when a patient comes from home or from another facility with a pressure area, as well as when a patient develops a pressure area in our facility. Is it necessary to report to PACERS in each of these cases?
Thanks, Jeff. To answer the question, no, you are not required to submit an incident report into PACERS when a patient comes from home or from another facility with a pressure injury. So that would be considered a pressure injury upon admission. However, it's important to get that baseline skin assessment in the instance that patient, it does worsen or progresses, in which case it would be considered reportable at that point, depending upon reportable as an incident or a serious event. And then if a patient develops a pressure injury in your facility, yes, that would be considered a reportable event into PACERS, either as an incident or a serious event, depending upon the treatment, additional healthcare services, the details of that event.
I have another question for one of the WOCNs, perhaps. Do you rely on the nurses staging, or do you only take staging of injuries from the WOCN?
This is Stormy. The nurses will document in their LDA to the best of their ability of what it is, but then we will go forth and assess the patient, and if they say it's stage 2, but it's really a stage 3, we can go back into the LDA and correct it.
This is Jennifer. A similar, Stormy. We have a similar pathway here. One of the reasons why we ask them to use their words, as I continue to say, is because sometimes they will stage, what we'll see is a stage 2, which then they'll say open with fluff. And so those are some of the challenges which we know from afar in that LDA don't necessarily match up. So we do take our validated staging for reporting purposes. But speaking to some of those inconsistencies in staging accuracy, with the nurses certainly continues to be a challenge and continues to be an opportunity for education.
Hey, thank you. I have a follow-up question from the question about the photos being taken. They're asking to clarify again how often the photos are taken.
So our photos are taken on assessment of the patient, and then we will follow up with the patient. If it's earlier in the week, we'll follow up with the patient about 3 days later and see how the treatment is going, or we may follow up with the patient the following week. And we typically will then see the patient every week, and we will take pictures and measurements at that time.
This is Jennifer. We're similar. Certainly a deep tissue injury can evolve and kind of provide an etiology within 2 to 3 days. So on assessment of the WOCN, we take a picture initially, and then on follow-up, again by the WOCN, either 3 to 5 days, we take a second follow-up picture to see the progression or resolve often of that area if it's a stage 1 or 2 and interventions have been put in place. We do not do pictures on admission by staff.
Okay, thank you. And next question, in the event reporting, I think it was RL, how were the questions in the event report built to match the reporting criteria? Was this provided by the vendor, or did your organization customize it?
Jeff, this is Gail from Reading. We work with our vendor, RL Solutions, and they help to ensure that the questions that were required for reporting were entered into RL Solutions.
We've done the same thing. Our vendor is Midas, and we've worked with them to assure that questions on our event report match what's in the authority's website.
Okay. I have another question. It says for Reading Hospital, They indicated they keep their incidents open until the patient is discharged. Does that mean they are not reporting these to pacers until then?
With that specific event-type pressure injuries, yes. We're waiting until the patient has been discharged, keeping in mind that we have 90 days to report an incident.
And we actually do the same thing here in Lancaster. If it's just an incident, we wait until they're discharged, just to assure that there's no progression of the wound until then.
Okay, thank you. There's a question, are there handouts for this conference? And I believe in the beginning we said that in the chat box there was a link to those, and you should be able to open up those from there. Here's another one. No, I'm sorry. They answered that question for you with the link. Would Reading Hospital be able to share the algorithm for interventions that are based on Braden's risk scores?
Our policy?
Just say, would you be able to share the algorithm for interventions that are based on Braden's risk scores?
So we have a policy that we have put in place with just like guidelines with our preventions, but if anyone wants to reach out, we can always send that over to them.
Okay, thank you. Here's one for anyone, I guess. How do you determine what is additional healthcare services?
Here at Lancaster, we tend to decide, is it a prescribed medication? Is it something only a licensed provider can prescribe or use? Or is it something, even though the provider may prescribe it in-house, can a mom go to CVS and purchase it? So are we doing some sort of non-prescribed medication or just offloading or repositioning, those kind of things? Or are we using something that only a licensed provider can provide?
And we do the same thing at Reading as well.
Okay, thank you. Okay, who documents unavoidable? The physician, the WOCN, and how soon in relation to admission to the hospital?
I think that's an interesting question because I don't know that we specifically document unavoidable because those are still counted within the system at this point that we know of. We continue to certainly understand based on our why questions and all the interventions that we have in place, but I am not aware of unavoidable being pulled out of the nomenclature at this time.
Okay, this next question looks like it's for Reading also. Have you had any issues with nursing documenting that an injury was present on admission despite it being a few days from the actual admit date? We struggle at our facility with this.
Now, the staff's pretty good at picking up on the wounds on admission. If they notice anything after, the sheet that they fill out for the LDA has a question implemented already made into it that states, was this present on admission, yes or no? So they will click the no, and that's when we find out about, we'll get the consult put in. But we usually don't have any incidents where the staff are backdating that something was present on admission and a few days later.
Next question, why do you, why do you ask 2 RNs or staff members to conduct the initial admission assessment?
This is Jennifer at Lancaster General. For our purposes, really wound care and skin assessment in general can be very subjective. I would love to say that it's not, and we try our best to provide parameters, but sets of eyes to do a head-to-toe and validating with each other provided greater accuracy. Certainly with new staff and more seasoned staff, that also is the case, to provide a kind of more seasoned set of eyes as well. So 2 sets of eyes were better than 1 is what we found.
Okay, with incontinence-associated breakdown that occurs in the gluteal cleft, progresses from partial to full thickness, is it now considered a stage 3 pressure injury?
Hi, this is Stormy. Now, if it's with moisture, we keep it as a moisture unless we notice that if we have reasoning against that. But we don't typically take a moisture associated and turn into pressure unless we know for a fact that it is.
This is Jennifer. I agree. We the depth of the injury, whether it be moisture, yeast, or or pressure. Those are three different etiologies, and the depth of the injury itself does not change the etiology from one to the other.
I now want to thank everyone for joining us today. This concludes our webinar. Thank you.